So we're back again, and now the topic is going to be taking apart the immune response that we have been so laboriously building up. Because remember, every step in the process of the engineering design can have a defect. And as you've noticed, I've had several case histories that I have appended to chapters or maybe free floating on the website that deal with the problems of particular steps in the development of the immune response. So the purpose of this chapter is to simply put them all in one place, to group them together as to what portion of the immune response has the defect, and then to compare them side by side. Because realize most step 1 and step 2 and step 3 questions start with the patient, expect you to work through the chief complaint into history and physical, make a diagnosis, and then either answer some basic science question about why the patient looks the way they do, or indeed propose some sort of therapy that might improve their case. So as you notice here, in the primary immunodeficiencies, what we're talking about is mutations that affect the development and functioning of the immune response. And they normally present quite early in life. So remember, as you ask yourself the question, is this of a particular age, of a particular gender, of a particular time frame? Then those things will generally indicate to you in the stem that it happens after the maternal passive protection has waned. So that 6 to 9 months grace period when transplacental antibody protection keeps the child in fairly good health. Then once the child tries to develop their own immune response, things become an issue. So let's start at the top of the nirvana diagram. Let's start with our discussion of defects of phagocytic and antigen presenting cells, because of course you realize if I've got a problem at the top of the diagram, it's going to manifest the whole way down the chain. It's going to start out being a child with repeated infections, usually with extracellular microbes. And so of the ones that I gave you particular case histories of, you should have seen the one on chronic granulomatous disease, and I also mentioned that as we went through that chapter, and the one on leukocyte adhesion deficiency. And I've arranged these from left to right across the page in the order of their likelihood of being questioned. All of these are rare genetic conditions, but when a rare genetic condition demonstrates some principle of immunology, it becomes a very good way for them to test to see if you understood how that is supposed to work. So starting over here on the furthermost to the left, chronic granulomatous disease, as I believe I said before, is the most commonly asked scenario on the step 1 exam overall in immuno, because it's a very nice demonstration of whether or not you understand how you have intracellular killing inside your phagocytic cells. As such, it's a deficiency of NADPH oxidase, which, if you recall, means you can't generate that first wave of oxygen radicals off of the respiratory burst. So what that means is that if I am infected with a catalase-positive organism, that organism is going to make the enzyme that destroys the efficiency of my second oxygen-dependent mechanism, namely my myeloperoxidase. And notice down here, when I speak about myeloperoxidase deficiency on its own, by itself, it would be an asymptomatic condition, and they're not going to ask you about that because of the fact they would have to give you a patient with no clinical signs or symptoms, and that would be a pretty boring stem to start with. So realize the problem in CGD is when I have one of the processes that are oxygen dependent and generating radicals missing genetically, and the second one knocked out by the catalase positive organisms. And here is the mnemonic that I use for those organisms to remind me the most important ones that are generally involved in the condition of CGD. Okay? Now, how do I diagnose CGD? They may mention the nitro-blue tetrasolium dye test. Realize the dye is yellow to begin with. When I feed it to phagocytes, if there is a drop in pH in the phagosome, it will turn blue. Okay? So don't let the name make you think the dye starts being blue. It turns blue in the presence of acidic pH. So if it turns blue, then I have a positive result, and I know that the patient does not have CGD. Okay, now that's a little bit different. Generally, a positive result of a test is the diagnostic answer yes. But in this case, a positive on nitro-blue tetrasolium tells me those phagocytic cells are just fine. They are reducing material inside the phagolysosome and therefore doing what they're supposed to be doing. I can also measure that pH fall using flow cytometry, and the neutrophil oxidative index is the name of that test. We will talk about flow cytometry a little bit later in the progression here. But any value less than 73 would be considered diagnostic of a problem in the ability of the phagocyte to oxidize the contents of their phagolysosome. How do I treat these conditions? With interferon gamma. Remember, that is the product of a T helper 1 cell that acts on phagocytic cells to make them more aggressive and efficient in their phagocytosis. Now, remember from your biochemistry that if I had a problem with G6PD deficiency, that would span downstream to causing the same problems with the inability to generate NADPH oxidase. But if you try to organize your thinking from the patient, you would realize then that a patient with G6PD deficiency is generally asymptomatic until there's some sort of stress that happens in their life, like an infection, like a treatment with a drug. And in those cases, how they present is with the anemic crisis that is reflected by that deficiency. They generally would not be aware of having had any phagocytic problem. Leukocyte adhesion deficiency, a deficiency of CD18 from my beta-2 integrins. So remember, those are involved in the tight binding that allows my white blood cells to leave the circulation and go into areas where they are needed that are inflammatory sites. So I'm not going to be able to create abscesses or pus. I'm going to have deficiencies in wound healing, one of the first of which is going to be omphallitis, the failure to reject the umbilical stump. So again, you have case histories of these that are quite involved that I think you'll learn a lot about as you read them through, because they're designed from the patient down to the therapy, the whole way through stepwise, what you would do as a physician. Now, the other two in this chart are much less frequently asked, and I'm going to suggest to you that for Shiraya-Higashi syndrome, it's a defect in a gene that affects the synthesis and storage of granules. So remember that it's going to affect both my phagocytes and my natural killer cells. And if they describe giant granules inside those two populations of cells, along with a patient who has partial oculocutaneous albinism, then you should be suspicious of this problem. Now, there's not a lot that they can ask beyond that. Again, unbelievably rare, but the deficiency is a problem of ability to mobilize granules. Hyper IgE syndrome is a defect in one of your signal transduction molecules that is important, if you recall, in the production of several inflammatory cytokines. interleukin 17, 21, and 22. So I see a broad range of different phenomena in these patients: eosinophilia, eczema, increased IgE synthesis, abscesses that are not warm to the touch, so clearly they are not inflammatory in nature, retained primary teeth, and recurrent infections of the skin and the respiratory mucosa. This one had the name a while back of Job syndrome, alluding to the character in the Bible who had all of the problems that the Lord gave to him. Okay, so the problems of Job. And as you notice from this, it's sort of hard to understand what unifies these unless you remember how the signal transduction pathways work in my T helper cells that we discussed earlier. I have never heard of them asking of Job syndrome, and quite frankly, if I were going to construct a question, I would tell you what the problem is, namely the failure of ability to produce those cytokines, and then make it a question about how do those cytokines work rather than one about making the diagnosis. When we have defects of the humoral system, I think it should stand to reason that the humoral system may have problems involving all categories of microbes, or if it's a specific deficiency that involves IgA in particular, I may have a predominance of infections of the skin and mucosal surfaces instead. So once again, shouldn't surprise you, it's going to be a child brought in for evaluation after recurrent infections. If the categories of microbes are across the field, viruses, bacteria, fungi, parasites, and I have no circulating B cells in the blood, remember I would count them using CD21. Usually, I can also use 19 and 20, so anything 19, 20, 21 specific for B cells. The problem in Bruton's, which is my first one in the farthest left column, is that I have a stopping of development of B cells at the pre-B level. And if you recall what a pre-B is, it's a cell that has mu heavy chains in the cytoplasm, but is unable to progress past that. So in this case, that is the case of arrested development of the cells, which means that I will not have any of those cells released from the bone marrow because they've not completed their development. It's a problem with a tyrosine kinase that's involved in B lymphocyte maturation. Okay, I'm going to treat those patients with antibiotics and immunoglobulins. Moving on, if I have normal T and B cell numbers instead, rather than a deficiency of B cells, and I have normal to elevated amounts of IgM in the absence of the other isotypes, then recall I did give you a case history on hyper-IgM syndrome, which is a genetic deficiency of CD40 ligand on T helper cells. Okay, now with those, again, I'm going to treat with antibiotics and immunoglobulin. Over time, these persons typically will do just fine as long as you get rid of infections quite quickly. Now, if I have the association of decreased immunoglobulin levels along with levels of autoimmunity, then this becomes a diagnosis of exclusion. I have to figure out what the problems are with what immunoglobulins, and it really could be any of them, reflecting either that I have a problem in the signaling from the T helper cell, or perhaps I have a germline problem in the B lymphocyte. With my selective IgA deficiency, if you recall, I mentioned this in our discussion of vaccination, because remember that when you think of the sequence of the germline DNA, I've drawn it several times for you, but it doesn't hurt to do it again. It would be VDJ, and then mu, and then delta, and then 4 gammas. I will just abbreviate that way. Then an alpha, and an epsilon, and the final alpha. So if I'm lacking the ability to make those alpha switch regions work, then what happens is I have a pre-inclination to switching toward IgE in unusual situations. And so often, retrospectively, we will realize that these patients have very high levels of atopic allergy. And as I said, we find those sometimes when we give perfectly well-matched transfusions and the minute amount of IgA in that transfused whole blood sets the patient off to having an anaphylactic reaction against that transfusion. So notice that although we give antibiotics in both of those last two cases, we do not give immunoglobulins to the patient with selective IgA deficiency, because that will induce them in some cases to make IgE against those immunoglobulins. And of course, anaphylaxis can be fatal in those scenarios. Complement deficiencies. Remember, complement functions as an adjunct to antibody to either lyse or increase inflammation or increase phagocytosis of extracellular organisms. Particularly when they're encapsulated organisms, the problem is that a capsule makes you slippery or slimy. And so it's difficult for a phagocyte to get a grip on you if it doesn't have some additional means of doing that. So when we think about complement deficiencies, all of the pathways, if you recall, generate the membrane attack complex. So it could be true in any of them. If I can't make that membrane attack complex, I'm going to have trouble causing lysis of organisms. But it turns out to be true that the only organism that is truly exquisitely susceptible to complement-mediated lysis is the genus Neisseria. We can't explain it, although I will say to you that my personal predilection is that it's because of the fact that Neisserial organisms constitutively overproduce membrane fragments. And so if the factory for membrane is already stressed to its limit, then adding on a serum component that destroys membrane could indeed push Neisseria over the edge. But when I have a patient who's unable to make the membrane attack component, what happens is that they will present with repeated Neisserial bacteremias. Now remember that when I have the need to remove immune complexes from my system, that is normally taken care of by my spleen. And my spleen has phagocytes that have receptors for C3b. So if I have a problem with a patient who doesn't make C3b from any of the pathways, then I'm going to see the problem that those immune complexes have more difficulty being removed from the blood. So I will see deposition of those complexes in the small to medium-sized blood vessels. And what will happen then is that I will develop fibrinoid necrosis in those blood vessels that can be quite damaging. Now realize if I have antibody that's starting this problem, it's going to have the issue of a deficiency of 1 and 4 and 2 components, because those are the ones who are activated by antibody. And if I cannot create those components, then I can't activate the classical cascade. And again, I can be at risk for problems due to that fact. What do I do with these patients? I simply replace the components from fresh filtered blood that has plasma that has been purified in order to get the individual components. Deficiency of complement regulation, I alluded to earlier in one of our make me care scenarios. But remember that if I cannot regulate the complement system by applying the brakes in the system when needed, then I've got the problem that the cascade will run on until the next step. Okay, so a little review here. The cascade goes 1, 4, 2, 3, and then 5 through 9. And I have brakes on the system at the odd number components. I have brakes at 1, I have brakes at 3, and I have brakes at 5. So if my brakes fail at 1, the cascade will run until 3. If my brakes fail at 3, the cascade will run until the next one. And then beyond that, generally the membrane attack complex will just continue to be made regardless. So if we have a patient who has a deficiency of C1 inhibitor, realize what I'm saying is that the train has lost its brakes at that point. So this is going to affect the patient by having the cascade run until the next brakes. So if I look in the serum of these patients, I would see reduced levels of C1 and 4 and 2 in the serum or plasma. Because my second braking system comes in at 3, I'm going to have normal amounts of those because the system shut itself down. So the way I diagnose this is by actually identifying those reduced plasma levels of those early components which affect only the classical cascade. In the case of the person who has paroxysmal nocturnal hemoglobinuria, realize that my problem now is the issue with the common membrane anchor that attaches CD55 and CD59 to the surface of my red blood cells. Red blood cells have to exist in the blood at all times, and so if I am lacking that anchor for genetic reasons, then what will happen is that my cascade will lose those two braking systems. And so the cells with no protection will be susceptible to hemolysis, which I typically see in the morning, either due to the fact that I have increased acid in the blood from shallow breathing at night, or because of the fact that the urine is simply more concentrated and therefore the blood is more visible. But it's a patient with morning hemoglobinuria, and it is solved by stem cell transplant or by treatment with eculizumab, which is a monoclonal that blocks the formation of the membrane attack complex. I should have mentioned the classical cascade problem with C1 inhibitor being lacking causes hereditary angioedema, and you should think of this as looking quite similar to a patient who has atopic allergy. It's repeated bouts of inflammation of the mucous membranes, and so that can look considerably like someone who has an allergic hypersensitivity to something. But again, we determine the issue by measuring those serum values, and we have some drugs that act through decreasing plasma kallikrein in order to help these patients. Ruconest is a recombinant preparation of C1 inhibitor that can be given to these patients in order to ameliorate their problems. As we talk about our combined partial lymphocyte defects, realize we've got Wiskott-Aldrich syndrome and ataxia-telangiectasia, both extremely rare genetic defects that I think probably you would only be asked at the level of identifying the child with the problem. But in the case of Wiskott-Aldrich, it's going to be a male child because it's an X-linked attribute within the first year of life who is going to present with thrombocytopenia, eczema, and recurrent infections. We refer to that as the Wiskott-Aldrich triad: the thrombocyte problems, the eczema, and the infections. Realize that these patients will have low levels of some types of immunoglobulin, and that may be variable, but the presence of immunoglobulin changes along with thrombocytopenia and eczema is what's going to give you your diagnosis. Stem cell transplantation is what we have to do. The genetic defect is of the Wiskott-Aldrich syndrome protein, cleverly named, so that doesn't make for a very good question, but it's involved in cytoskeletal signaling. Other than that, we don't know much about it. As I said, my guess would be that questions on this subject would be almost purely diagnostic. Ataxia telangiectasia, the name is quite descriptive. It's a child with a staggering cerebellar gait, ataxia. Telangiectasias, those spider-like dilatations of the vasculature of the eye and the pinna. This is a patient with thymic aplasia and sinopulmonary infections and failure to produce normal amounts of IgA. I would find these patients with lower than normal T cell counts and a poor ability to clone T cells. And the problem is an ATM kinase, ataxia telangiectasia mutant protein kinase, which is a molecule involved in repairing double-stranded DNA breaks. Okay, it's inherited in an autosomal dominant, autosomal recessive condition, and we treat with antibiotics. As you can imagine, as we move into the defects of T cells, we're going to anticipate that our patients would have more wide-ranging problems. Because remember, my helper T cells are the generals of my immunologic army, and my killer T cells are the most important effectors against viral infections. So if I see a patient who has decreased T cell numbers of all categories, remember the marker I would use for that purpose would be CD3. That's found on all T cells. If I have only decreased CD8 values, then remember I'm going to compromise on that by increasing the innate component cells that lead into that particular pathway. So as I lose the adaptive killer cells, I find increased levels of natural killers and gamma delta T cells. The innate system on that edge takes over. Now, as we start here, what used to be called DeGeorge syndrome is now more appropriately called 22q11 deletion syndrome, and that's because it's very descriptive of where the condition is found genetically. It's on chromosome 22 on the long arm, and it's a deletion syndrome and results in a failure of formation of the third and fourth pharyngeal pouches. So if you think about what is found in those regions embryologically, it shouldn't surprise you that we associate this with things like truncus arteriosus, with failure of formation of the parathyroids, and with failure of formation of the thymus, as well as some facial abnormalities. All of those come out of those same embryological origins. Now, because of the aplasia of the thymus, you would anticipate that the child is going to have problems with T cell development, of course, and it's diagnosed at the current time by finding the lowered number of T cell receptor excision circles as detected by PCR. This is a test that's now done at birth to detect these sorts of global T cell deficiencies. Because if my T cells are not going through VDJ recombination as they should in development, then I would have lower numbers of those excision circles, and it indicates that I've got a deficiency on that arm. Calcium supplementation, because of the issue with the parathyroids, is often necessary. Thymic transplant has been done, but depending on the size of the deletion, these can be lethal mutations. In the individual who has bare lymphocyte syndrome type 1, realize that this is a condition where I've got a problem with expression of MHC class 1. And usually it results from a failure of those transporter proteins, which are necessary for taking peptides and joining them to the newly forming MHC class 1 molecule as it arises in the endoplasmic reticulum. So I think it shouldn't surprise you that I'm going to have problems in these patients with the skin. I'm going to have problems with the respiratory tract. And in addition, because of the fact that I can't make high numbers of CD8 cells, over time I will have very severe infections with viruses over time. The necrotization that we see is because of the fact that I've got increased innate levels of those cells that would lead in to a normal CD8 response. In the absence of those responses being available, I have sort of an undampened innate response on that arm. The diagnosis is by looking for HLA class 1 on the cells of the patient, usually by fluorescence activated cell sorter. Treatment, antibiotics, physiotherapy of the chest because of the recurrent infections. Now, the severe combined immunodeficiencies, of course, are the most severe and debilitating of the primary immunodeficiencies. And so again, it's going to be that age group once the maternal antibody is gone, and the child is going to have recurrent chronic infections of all types of microbes, all locations, normal flora, and a deficiency of numbers of lymphocytes. So a pretty global problem with the lymphocytes. Now, I always try to tell students that there's a silly memory tool for this that I call the Roubush rule of twos. And those of you who haven't studied with me before haven't heard this. But the Roubush rule of twos basically says that stimulation of my system at the MHC class 2 level causes the generation of interleukin 2 on the cell-mediated side, or interleukin 4 on the humoral side, and the production of either of those cytokines, 2 or 2 times 2, causes any cell that's capable of doing this to divide in two. My point being that this is the major focal point for all cloning signaling within your immune response. And remember, cloning is the way I develop my immunological muscles. So notice that at least 2 of these severe combined immunodeficiencies are failures of some component of the Roubush rule of twos. The first one, bare lymphocyte syndrome, is a problem with expression of MHC class 2. And realize as a result of that, I'm going to have no T helper cells produced out of the thymus, and I'm going to have an inability to create T cell dependent antibodies. Now, graft versus host disease is something we'll talk about in transplantation. But if you recall, what graft versus host disease is a reaction of engrafted tissues from the bone marrow, realizing that they don't like the location that they are in the host that they have been given to. It's the reverse of the normal transplant rejection reaction, where if you give me a kidney, my immune response looks at the kidney, says, that's not me, I don't like it, and tries to destroy it. Well, in this case, it is the cells that have been donated from the bone marrow that have to multiply in order to reach a number that is sufficient to cause injury to the much larger organism. And as that implies, as I just described it, although I'll do it in more detail later, realize that that implies I have to have a mechanism for cloning cells in order for graft versus host disease to occur. And that's why it's here in this list. The second failure of the Roubush rule of twos, that was this one. Okay. The second one is the problem with the ability to recognize the signal to clone on cells. And notice that if I have a deficiency of that receptor, it affects both 2 and 2 times 2. So both the cell-mediated and the humoral arms do not have their normal cloning signals. So these reflect as severe combined immunodeficiencies because I cannot multiply the number of cells that I have originally responding. The next 2 of the severe combined immunodeficiencies are not problems with the Roubush rule of twos, but instead, in the case of the RAG gene issues we spoke about very early on when we were doing VDJ recombination, realize that if I cannot do VDJ recombination, I cannot make functional lymphocytes of any kind. Therefore, I have no B cells or T cells in the blood, and I have a severe combined immunodeficiency. Finally, adenosine deaminase deficiency results in a buildup of a toxic product of purine metabolism in the developing cells in the bone marrow, and as a result, I do not turn out any functional lymphocytes from that process of development. All right? I did not put a hashtag MMR in this chapter because it occurred to me that unless you really don't want to be a doctor, it should be fairly intuitively obvious why it's important for you to be able to identify these diseases. After all, that's why you're studying so hard to get past this exam. So I just didn't think it was necessary for me to point out the value of being able to diagnose the immunodeficiency diseases. But as always, my summary comment here is to make sure that you can diagnose these from the patient presentation as far as you can back toward the molecular details of how the process is occurring. And when we have a therapy that is available, make certain that you can explain the mechanism by which that therapy works.